It's my absolute pleasure to introduce our panel tonight. These panel members represent a great breadth of research and impact in our community. And as I said previously, we fund over 60 areas of health and medical research. But tonight we picked 3 areas to do a deep dive into: prostate cancer, dementia, and pregnancy care. As a survivor of prostate cancer, I can tell you it's important. We probably all know someone in our friendship group or our family members who are suffering the impact of neurodegenerative disease, whether it's dementia or Parkinson's or one of the others. And we have to populate the country, and therefore pregnancy care is very important. So they couldn't be more different in the areas we want to talk about, but that's the beauty of our organisation. And no matter what healthcare area that you're close to, we're probably doing something to support it with your generous, kind support. So first of all, I'd like to introduce Professor Luke Selth, who's the head of Prostate Cancer Research Group at Flinders Health and Medical Research Institute. His research program is internationally recognised, and we've been supporting Luke for many years now. Welcome, Luke. Thank you. First up gets to choose the seat. Okay. Yeah. Next, I'd like to introduce Dr. Karen Best, who leads the Pregnancy and Newborn Health Program at SAHMRI and Adelaide University. She's been spearheading world-leading research into the link between omega-3 levels in preterm births, and that's led to changes in South Australia as a first for routine testing for pregnant women. It's great to have you here, Karen. And lastly, I'd like to introduce Dr. Chris Belder. Chris is our Hospital Research Foundation Dementia Fellow and a consultant neurologist at the RAH and the QEH. He's internationally recognised dementia expert, and we're really pleased to help lure Chris back to South Australia several years ago to help prepare South Australia and the patients in South Australia for new dementia treatments that are becoming available. So welcome, Chris. I'm going to stand behind you guys. You don't look at me. Don't look at me. So first of all, starting with you, Luke, this is an unashamed plug. Can you talk to our colleagues here in the audience about how the Hospital Research Foundation has helped you, and then after you, Karen, and after you, Chris, please.
Sure. Thanks very much, Paul. So the focus of our research group, as you've heard, is prostate cancer. We all know this is a massive problem in Australia and around the world. We do lots of different research in my group, everything from fundamental research, trying to understand what makes prostate cancer cells tick, all the way through to developing new therapies and biomarkers for the disease. And the THRF have been a wonderful supporter of our group and currently supporting a grant in which we are developing new biomarkers for the diagnosis of prostate cancer. So prostate cancer diagnosis might seem simple. Actually, it's pretty complicated. It can be a challenging fact-finding exercise. There's lots of tests and exams. There's a blood test, PSA. There's imaging with MRI. There's biopsy to really have a look at the tissue. But despite all of these sort of diagnostic tests, there's still some challenges. And one of them is that it can be quite difficult to accurately identify and also differentiate between the tumours that are really aggressive that we have to treat versus the slow-growing tumours that probably won't affect a man's quality or length of life. We call those indolent tumours. So what we're doing is trying to improve this diagnostic process essentially, and we're actually investigating a completely new class of biomarkers. They're called SNO-RNAs, and we're looking at the levels of SNO-RNAs in tumours in the blood. And what we found is that in tissues, in the prostate cancer tissues, SNO-RNAs are very good at predicting future metastasis, so they're really good at telling us how aggressive the tumour is. And with the funding from THRF, what we're doing is developing tests to measure these SNO-RNAs in the blood. And we're hoping that this could improve the diagnostic process and specifically help us to better stratify the different types of prostate cancer that a man can be diagnosed with.
You've just answered 4 of my questions. Karen, if you can share a little bit about this omega-3 amazing thing that's been discovered and rolled out of SAHMRI and Adelaide Uni?
Sure. So my pregnancy research group, we focused mainly on interventions during pregnancy to improve lifelong health of mums and babies. We have a major focus on the prevention of preterm birth, which affects around 1 in 12 babies. Preterm birth is actually the single greatest cause of death and disability in childhood in Australia. And a lot of our work around preterm birth prevention has focused on omega-3 long-chain polyunsaturated fatty acids. It's a long name, but they're really just the fats that are found in fish and in seafood. And we've done a lot of work over the years, which has informed updates to the National Pregnancy Clinical Guidelines. And those updates recommended that women with low omega-3 in early pregnancy should take supplements to reduce their risk of having a preterm baby. So with all of the research we've done, that's when we were faced with a real world problem, because we had all the evidence, but we had no way in the health system at the time to actually check who was low in omega-3, who needed advice around taking omega-3 supplements. So that's when in 2021 we launched the omega-3 Test and Treat program in partnership with SA Pathology. And the program is essentially offering a free omega-3 test to all South Australian women, and then depending on what their result is, they get specific advice tailored to them so they can prevent their risk of preterm birth. So we started, as I said, in 21. We were doing very well. We applied for MRFF funding and were unsuccessful to keep going with the program. But then thankfully the Hospital Research Foundation group stepped in and gave us some funding. This enabled us to reach so many more women and clinicians around the state so that we could increase awareness of the program. It also increased the uptake of the program and helped us leverage more MRFF funding that we were actually successful for the second time, because we'd had the Hospital Research Foundation funding. So we wouldn't actually be where we are today without that. And with over 35,000 South Australian women have now had an omega-3 test and have been able to find out their results and see what their risk of preterm birth is.
And Chris, a couple of years ago, I had Tim Kleinig's here tonight. Welcome, Professor Kleinig. And I had Tim and a couple of his colleagues in our office, and they were like giggling children because there was an opportunity to bring Chris Belder back to South Australia. And the work that you're doing and the way they explained it to us, it was exactly the work you're doing, is quite remarkable, particularly leading to the release of some new medication. Do you want to tell us a little bit about that?
Yeah, so thank you for those incredibly kind words. So I'm a neurologist. I work at the Queen Elizabeth Hospital in the Cognitive Neurology Service and in Cognitive Neurology Clinical Trials. And we really support a wide range of research and clinical trials looking to develop better, improve the diagnosis and treatment of dementia. Dementia, I think, is the great healthcare challenge of our time. It's now the leading cause of death in Australia, and in addition to that, it has significant impacts on people living with and caring for those with dementia. There have been really, really incredible advances in the research space around dementia and the various causes of dementia. And really the focus of my role, which the Hospital Research Foundation inaugurated and to support my return from University College London, is really looking at how we can develop the systems of care to take these tests and treatments from the research space into routine clinical care to improve the lives of people suffering from dementia.
And staying with you, Chris, the improvements in care is kind of incremental, isn't it? I mean, we're not curing dementia, but we actually have to take small steps when they're available. And one of the new medications that you're working with will make one of those small incremental steps. and I can recall you telling me the numbers, I'm not going to try and repeat them, but from our perspective, what you do, what all of you do, but what you do is give hope. And do you want to talk a little bit about that kind of incremental increases over the years in care?
Yeah, and I think not just incremental, I think at the moment we're really at the start of a transformation in dementia care and support. So people probably saw last year there were 2 new medicines approved for the treatment of Alzheimer's disease. And these are the first medications that have been approved in this space for, I think, around 20 years. So taking a step back, dementia has many causes, but Alzheimer's disease is the most common. And it's a complex disease, but one of the earliest changes that happens in the brain is the build-up of an abnormal protein in the form of what are called amyloid plaques. So these 2 new medications that have been approved, they're intravenous medications. They're given through a drip, and in very large international clinical trials have been shown to slow the decline in cognition and function that's seen in Alzheimer's disease. So these were very large international trials, and for people with the early stages of Alzheimer's disease. So these are people who have cognitive symptoms but don't yet have significant change in their day-to-day function. And by administering these medications either 2 weekly or every 4 weeks, they showed that you can very, very significantly remove these plaques from the brain, detected with specialised PET scanners. So further highlighting the impact that this will have the PET scanner will have an impact on dementia care as well as of cancer, and so I'm incredibly grateful for that.
See, I told you, Chris.
And so these are the first medications that have been shown to slow the decline in the early stages of Alzheimer's disease. Now, these medications aren't for everyone with dementia or Alzheimer's disease. There are specialised tests that are required to determine eligibility, and because of some potentially significant side effects, people require close monitoring during treatment. But I think this represents the start of a new age in dementia care and treatment.
Yeah, thanks, Chris. That's a great explanation. Karen, you work with some wonderful people. You work with Maria Macready's. Am I right in saying this omega-3 connection to preterm birth almost came about as accident? Is that right?
Yeah, kind of. We originally, our first omega-3 in pregnancy national trial that we did with around 2,500 women, we were looking at the effects on postnatal depression and child development. Unfortunately, we didn't see the improvements in those outcomes that we had hoped. But when we looked closer at our broader outcomes, we saw that there were fewer preterm births in the group of women who had been taking omega-3 supplements. So from there, we thought there was 2 more big pieces of work we need to do. One was a big review of all of the evidence around the world of pregnancy trials involving omega-3 supplementation. So we did that. That was a Cochrane review that included over 20,000 women, and that showed similar results to our Domino trial, that omega-3 could actually reduce the risk of preterm birth. But that wasn't enough. We also did another large national trial called the ORIP trial, and that included 5,500 women, and that was designed specifically to look at whether omega-3 supplements could reduce the risk of early preterm birth, which is birth before 34 weeks gestation. And so that was designed around that so we could see that outcome and really find out who was going to benefit most from taking supplements in pregnancy.
So, and that's really interesting, and I'm sure all of you would have a story about this, but the ability for a funder to allow the researcher to pivot when that's where the evidence is taking you. Not always easy. My colleagues here tonight, Jim, Dee, Kelly Banwell and Anthea, who work in our research department, they spend about 70% of their time managing existing grants, and sometimes they are talking to people who've said, look, we tried this, but we think it's better to redirect to that. And as a private funder, we actually have the ability to do that, and it sounds like this has really worked in this particular case. Yeah. Luke, your research into, very close to my heart, your research into prostate cancer has taken you in a number of different directions. I know your program is quite vast. You talked about indolent tumours, and that's probably important for people to understand. Is, if you have symptoms and you go to your GP and the GP says, I want to send you to your urologist, and the urologist says, oh, look, after tests, we've identified that you've got an indolent tumour. Indolent basically means lazy, correct? Yeah. And so one of the important things about being diagnosed with prostate cancer is the ability for you and your clinician to understand when it's time to act and when it's not time to act. Do you want to talk a little bit about that? I know you're not a clinician, but talk a little bit about that.
Yeah, happy to have a chat about that, and thank you.
You answered all my other questions.
So, firstly, before I answer that, Paul, can I say thanks to you for being very open about your prostate cancer journey?
I can show you if you want, but...
Well, I don't need to see it, but we've had a few chats about it over the years, and it's really important for everyone, but particularly researchers like myself, to listen to people with lived experience, so thank you for that. Right, so getting back to treatment and how we deal with... We're talking here about localised prostate cancer, really. And as you've alluded to, there's different treatment options. So for the tumours that are life-threatening, we want to treat those with surgery or radiotherapy. Sometimes we'll use something like hormone therapy as well. There are a subset of tumours, which, yes, we refer to as indolent, that we don't want to treat because they're not going to affect a man's quality or length of life. And so there is an approach that we call active surveillance, which is basically active monitoring of the tumour, but no treatment. And this is really good. This is a really smart approach, and it's increasingly used in Australia. One issue is, and this is where our research comes in, as I said, it can still be difficult to say with certainty that a particular tumour is suitable for active surveillance, right? And so often clinicians and patients will err on the side of caution, quite understandably, and have treatment. And this sort of raises another issue of what we refer to as over-treatment. We know that we're treating cancers that don't need to be treated because they're not going to, kill a man or even affect his quality or length of life. And so, yeah, this is a really important issue that we're trying to grapple with. Of course, the over-treatment then is associated with unnecessary side effects and costs to the health system. Then just going back to what I was talking about earlier about the aggressive tumours, we have these tumours as well that are really dangerous, that could be life-threatening. And the danger there is some of them can actually be undertreated. So really what our research is trying to do, in a nutshell, is better identify and differentiate between these different types of cancers. And it could have some really powerful benefits. So for the indolent tumours, we avoid the unnecessary treatment, we avoid the side effects on the patient and the cost to the health system. For the really aggressive tumours, we treat those appropriately and hopefully cure the patients before the cancer can spread around the body.
So some of the research that you're undertaking helps the urologist identify what is, if you like, truly indolent and just active maintenance, and what perhaps could be a little bit risky and we should actively maintain it more regularly.
That's the goal, yes.
Thank you. Chris, this medication that we've talked about has been TGA approved, Therapeutic Goods Administration approved, but it's not on the PBS yet. Okay. So in the audience tonight, we just happen to have the opposition spokesperson for health and the member for STIRT, Claire Clutterham. So what would you like to say to them? to the government. Yeah.
So, I mean, I won't make any demands of our guests here. But you're right. They've been approved by the Therapeutic Goods Administration, but they're not yet available or publicly reimbursed. So at the moment, they're only available to people either through private funding or through clinical trials. And I would like to take the opportunity to highlight the work of one of my colleagues, Dr. Kathy Short, who actually, those trials that I mentioned before, very large international trials, but she was the South Australian principal investigator for both of those trials. So again, a demonstration of the impact that this work has had, that the Hospital Research Foundation has as well. I'm hopeful that these drugs, these medications will become more accessible. but also we're continuing to support research and conduct further clinical trials to try to build on these successes, to try to find the next generation of treatments that will be more effective, less burdensome, safer, and to look at targets that we know are important in Alzheimer's disease aside from the amyloid plaques that are the target of the current drugs.
And clearly, as a taxpayer, it's impossible to fund everything under the PBS. And so, part of the work you're doing is to try and provide more and more evidence to show that either this class of drugs or future classes of drugs can have an impact that is so targeted that it is worthwhile for the PBS to offer it. Without wanting to predict, I know that in some cases, some of these dementia-related illnesses can be delayed extensively and possibly even delayed maybe in the future permanently. And is that your goal? Is that the goal of all of you and your colleagues who are researching in this area?
Yeah, that is the goal. And, as I said, dementia has lots of causes, so there are lots and lots of things that require treatment. A lot of the current excitement and focus is on Alzheimer's disease, but there's a lot of research happening in other causes of dementia as well. The hope would be that through interventions, lifestyle interventions before, while people are well as then medications in people who are higher risk, that we hopefully could prevent dementia while someone is alive.
And speaking of lifestyle interventions, I'll just divert to a little story. Here tonight with us is Professor John Beltrami, and I was having a chat to John a little while ago, and I said to him, I might take a referral, John, if that's okay, to go and get a scan to see if I've got any plaque in my veins. And John said, what would you do if you have? And I said, well, I'd make some lifestyle changes. And he said, well, why don't you just make the lifestyle changes? Thank you, John. That was $400 well spent. Yeah. Karen, what are the next steps to roll this out nationally? I'm particularly interested, as our organisation is interested in the ability for these tests to be available for pregnant women in rural and remote communities, so that it can either trigger when it's time to come to the hospital or when it's time you don't have to. So what's the next steps for this treatment?
Yeah, so we've obviously established feasibility here in SA, where the omega-3 testing that we've been doing at SAHMRI will be taken over by SA Pathology next month. So we're now fully embedded in the health service here in SA. We are making plans already for national scale-up. We've applied for some government funding for a partnership grant to support that. So our goal is that an omega-3 test is available for all women in maternity care in Australia. So that's what we're going to be working towards.
And it's quite remarkable, SAHMRI, Adelaide Uni and SA Pathology being able to partner on this government department, a university and a research institute just to get to this point. I mean, collaboration is the key.
It has, and it's been a fantastic partnership and a really close collaboration. So we've actually, and in terms of prevention of preterm birth, we've done some independent modelling, and if we do scale this up nationally, we can prevent around 1,100 early preterm births each year around Australia, and these are the babies that can have the most significant problems. And it's also a really good return on investment with around $6.50 saved for every dollar spent. So it's a no-brainer, really, we think.
It is a no-brainer. And all of you have alluded tonight, and I might get you all to comment on it a little bit. There's a lot of research colleagues in the audience, a lot of clinical colleagues in the audience, but the vast majority of people here don't really get the opportunity to understand how hard it is to be wondering, you're some of the most intelligent people in our community, but you spend 30 or 40% of your time applying for grants. How difficult is that to balance against the life-saving impact you're trying to make? I'll start with you, Luke.
Yeah, thanks for bringing that up, Paul. This is a really big issue, and I think most people aren't aware of how hard it can be to do health and biomedical research in Australia. So interesting you bring up difficulties in funding. So currently the major funding schemes in Australia, the success rate is around 10%. So 1 in 10 grants are funded. And here I'm talking about the big funders like the National Health and Medical Research Council, which is the major government funder of research in Australia. So that's kind of shocking, and it has some massive issues and massive negative ramifications for the research we're trying to do. Firstly, there's all this outstanding research that is not happening. It's not being funded, so it's not happening, and it's a real shame because we don't know where the next sort of major breakthrough in health is going to come from, and if you don't fund the work, it's not going to happen. Secondly, and to be pretty blunt about it, it's a huge waste of time. You just mentioned this. So I spend probably a quarter of my time writing grant applications. When I was an early career researcher, I spent a lot more time than that. And this is time that I don't get to spend in the lab doing the research, looking for the next biomarker or therapy for prostate cancer. So it's a really, really big problem. And I mean, I've just put in a plug here for THRF. There have been multiple times throughout my career where, without funding from THRF and other organisations, we simply couldn't have done the research that we've done. So funding from the major sources has dried up, and it's only kept going because of funding from THRF and other organisations. So we're very grateful. I'm sure many of the researchers in the room would say the same thing as well.
Thank you. And Karen, I'm sure you've run into this type of thing over your research career?
Oh, absolutely. I'm waiting for an outcome of investigator grants at the moment. They're due any day now. But so much time goes in. But I think that's why, getting some smaller pockets of funding than the few million that you might be going for with the big grants is so important, because that can keep you going and can actually help you get that next grant. So that's where the Hospital Research Foundation and other, groups come in.
And Chris, you just swanned into a grant. But your career to date has taken you, to the far corners of the world, researching and working with some of the great experts in this area. It still has to be paid for.
And obviously I'm earlier in my career than Luke and Karen.
What do you mean by that?
But as a clinician researcher, I would say that dedicated funding for clinicians to do research is also hard because of the multiple competing demands in the healthcare system. If the hospital is paying you, they want to pay you to see patients, not conduct research. And so, that's why I'm incredibly grateful from the Hospital Research Foundation to fund a position that allows me to balance both clinical care and research.
So, look, please show your appreciation to our wonderful funded researchers tonight. We have some lovely gifts for you, which we won't make you cart around. You're taking time out of your day, and all of the clinicians and researchers that are here tonight taking time out of the day, we very much appreciate. So please give these guys another round of support as we let them sit down. So we've got another special little treat for you. Before we do that, I'd like to acknowledge one more person in the audience. Ukesh, where are you? Ukesh? Ukesh, stand up, please. Stand up. Ukesh works for the Multicultural Community Council and just recently won a Community Hero Award for the work he's doing through the Multicultural Communities Council. We're partnering with some of it. And he is making quite a contribution in the North African community. I hope you're proud of yourself. We're proud of you. Well done. So thank you for the guys that volunteered their time, and also thank you to Simon and his team for putting that vignette together. Hopefully it gives you a little bit of an insight into what it's like when you're diagnosed or when you have a challenge in your life, and we're really proud to be able to support those people, and I'm really proud of my colleagues to be able to support those people. just to follow Jess's lead, if you haven't had a chance, come down to Woodville Road, number 57, have a look at our brain and body fitness program. It's fantastic. They even let me in sometimes, which is good. And how can you help? Well, you can become a donor, you can become a regular giver. Homelottery.com.au, get in quickly, it's going to sell out. You can host a fundraiser in our longest table. You can get involved in our Giving Day coming up in June as a matched funder. Your business can take part in partnering with us to do activities. Where there's a will, we want to be in it, thank you. And you may wish to give while you live and really see the benefit of the impact that you're supporting. So on behalf of all at the Hospital Research Foundation, all of my colleagues, all of the board members, all of our volunteers, thank you very much for coming out tonight. Please enjoy some drinks and social time with some of our people, and please take the time to have a chat and find out a little bit more. Thank you.